Buttonology. This is just the geography of the ventilator, right? So this light bar across, that's the alarm lights. A yellow light says, hey, pay attention to me, yellow, orange. And then the red light says is an alarm that you absolutely have to address. The on-off button is a green illuminated button. You push it. It takes an annoyingly a long amount of time for it to turn on, but it's not so long that the patient dies in front of you. You'll see it when we start doing it. The other cool thing about this is when you hit that button, it starts ventilation from the standby screen. So if you're on the standby screen, you could hit start ventilation button on the touch screen, or you can actually just hit that on-off button and it starts the ventilations right away. When you're trying to turn off the ventilator, you can only turn the ventilator off in standby mode. So if the ventilator is actively ventilating, you can hold that power button all day and it won't do anything. It's a safety feature, right? Because you're not supposed to turn off the ventilator off when it's going. But just tapping it once, it'll bring up the standby screen, and then you hit activate standby to put it on pause. We'll demonstrate that here in a minute. Day and night mode, all it does is just dim the screen. Lock screen, this ventilator was meant to use pre-hospital and in-hospital, so you know, you could it allows you to lock the family out. So if you have like an overzealous medic student that keeps touching things, you could lock them out with that button. So, manual breath. The Ravel users, you know, in order for us to get a P-plat, you would do an inspiratory hold, right? And so when you see this button, you kind of make this association, but it's not. So number one, the Hamilton calculates P-plat, like on the fly, so you don't have to do an inspiratory hold. The value of this button is, say I tube somebody, and I might be at a rate of 10, so it's one breath every 6 seconds. But I tube somebody, so I want to hear all my lung fields, right? And so instead of waiting 6 seconds to hear epigastric, moving up to the left lobe, waiting 6 seconds, I can have my partner hit that mandatory breath so to create turbulence in the lungs so I could hear lung sounds. When you hit that button, like if I just tap it like this, it's like, it's not like a specific eye time. So if your partner's trying to listen for lung sounds, press and hold that button so it creates turbulence so they hear the breath, the air movement. When they move their stethoscope off, you can let go. So it's basically just you squeezing this inspiratory breath, creating air turbulence. And it's like as fast as you press it, as fast as it gives it. The FiO2 button, essentially think of this as your push dose oxygen, right? You tap this button for 2 minutes, you get 100% FiO2. After 2 minutes, it goes back down to whatever you were set at. So don't take a 10-minute transport and hit this 5 times, right? So this is an opportunity like, hey, I'm going to suction this patient, tap it, give him 100% FiO2, suction him, and then do whatever. Or, hey, this guy is crumping and he needs 100%, I'll tap it, but then I go into my controls, adjust my FiO2 or oxygen up to 100%, and then leave it. The print screen, anything that you see on the screen when you hit that button, it gets saved, and it gets saved to a thumb drive. The thumb drive you're going to use is from the Zoll monitor. So you get the Zoll monitor thumb drive, you'll just stretch it across, plug it into the side. I'll show you where to plug it in here in a minute. You hit that print screen button. The USB, if it's got a light on it, will flicker, and then that light up in the corner will flicker. When both lights are off is when you can remove that thumb drive. When you plug that into the computer, you'll see a bunch of your Zoll data, and then you'll see a folder that says screenshots. Those are all of your images will be in that folder. It's chronologically saved, so if you hit screenshots 10 times, it just saves it chronologically in that order. This is not for documentation. It's not for, hey, I'm going to hit a screenshot and I'm going to upload it to PCR and it's good to go. This is going to be more for your, hey, my patient was really messed up and I had crazy settings and it worked and here's proof of it. Or, hey, I'm getting this crazy alarm, there's a lot of things going on, take a screenshot and here's a record of it. For documentation, what I would suggest is when you pull up to the hospital, take your phone out, take a picture of the initial screen, and then take a picture of the page 3 under monitoring, and that gives you your P-plats and stuff like that, and then document with the image off your phone. You can do the print screen, but there's a lot more steps. You have to get the USB out, you have to plug it in, so the easiest way would just be take a picture of it on your phone.
Does it have any internal memory at all?
It actually does. But it's not user-friendly. And so what I mean by that is it has this log, and the log is 1,000 steps deep. So it historically historically maintains every event, 1,000 events. And so It doesn't separate it by patient either. So if you run a patient, like you'll see, my ventilator turned off, and then it gives you a rest. So at the end of the day, if you did forget to take a picture or something, you can go back. It's just not going to be as easy or convenient, but it's possible. The nebulizer button. So when we are nebulizing, we're going to use the Hamilton. And I'll be more specific. When you're nebulizing, non-invasive and invasive. Like if you're just doing a neb treatment, plug it up to the truck or the portable. Like you don't have to bring this whole thing in to do a T treatment. But if you're doing a neb treatment that's on BiPAP or they're intubated, we're going to plug into the ventilator, and I'll show you where that port is. And then we'll talk about some advantages and disadvantages of why we do that. Alarm silence button. Don't revel this. And what I mean by that is we're used to like smashing that down until the beeping stops and then like going on. This is a switch. You literally tap it once, you get silence for 2 minutes. And that actually gives you a little icon on the lower left-hand side, and it counts down 2 minutes. So if you tap it again within the 2 minutes, it cancels it out and your alarms kick back on. So just tap it once. The push to turn, so this is what you were familiar with in the Revell. Now I will say, the screen, it's touch screen, and it's pressure, not heat, right? So it's not like your phone where you wear gloves and you can't use it, like you have to have special heat transfer gloves. It's pressure, so you could use your pen, you could use a gloved hand. Where I will say, though, is if you're in a cold environment or your fingers are like massively fat and you're hitting like 3 buttons at once and you just get frustrated, you could use that dial and there'll be like a yellow cursor or yellow outline to go to the buttons. So the touchscreen, if you're having so much trouble with the touchscreen, turn that knob and it'll run through all the stuff that you need. You'll hit it and it'll be like, hey, I want to change FiO2, right? So when I hit that button, what I call is the control, the FiO2 value turns orange. When that thing is orange, you cannot do anything else other than adjust that value. So you can't change modes. You have to confirm whatever you're trying to change before you could go outside of that. And we'll see when we start demonstrating. Hot swappable battery, dude, we work in St. Charles County. You have inverters on your trucks. Like, we're not in boondock where it's a 10-hour train. Like, the battery lasts 9 hours. You should not be in a situation where we have to swap the battery out. There are 2 batteries. One of them was swappable. But like I said, in our environment, we're not going to do that as much. All right, so this side of the ventilator. I know you see those 3 ports up there, and on ours, there's just a board over it because we don't have that module. But your neb treatment is going to plug into that yellow port. And that's like, so as opposed to plugging it into the wall, you'll plug the tubing into that yellow port, and it'll neb on inhalation. So every time the patient takes a breath, it sends the neb treatment. On exhalation, it just shuts off. So your neb treatments essentially last twice as long because you're not wasting nebs during the exhalation phase. The flow sensor, so if you look at your circuit, you'll see this rubber hose. So because these are training circuits, your rubber hose is already separated, right? But if you trace it down, you'll see the part where the rubber hose is connected. So all of your new circuits, the rubber hose stays connected like this. So you have to like peel it apart like speaker wire. I don't like have fingernails and it hurts my hands to cut my nails too short. So I usually like have to use like Knox box keys or like something to help separate it before I pull it apart. So you may also have that problem if you don't have any fingernails, but it comes out and separates it. So the clear one goes in the white port, and then the blue one goes in the blue port. You would just snug them up. So then you have, that's the inspiratory outlet and the expiratory valve. So if you look at your circuit, it's got this triangle, right? The chevron triangle or the tubing, whatever, should be facing towards the front of the ventilator. If your ventilator has a tail, it will still work, but it's not going to be too happy, right? And so when you plug your circuit in, make sure that the chevron goes to the front of the ventilator and the tubing goes towards the front of the ventilator. Again, these are trained circuits that have been manipulated quite a bit, so they're pretty pliable. A fresh circuit, it's a pain to get it on. So one of the things I would suggest is you would use the bottom one in that expiratory valve, plug that in first. And once that's in, you can manipulate that top piece and turn it around and get it in. Your ventilator's not set up to plug this in right now because we're still missing a piece. So I know the image has this valve on there, but you guys don't have that piece plugged in yet, so that's why you can't attach your circuit yet, but we're getting there. The other side, this is where your USB port goes into. So it's that little rubber door. You peel that door off. You try 8 times, and then you finally get the USB plug in. This one right here is your oxygen, the high pressure oxygen. It'll already be connected. I just show the low pressure oxygen. Unlike the Revell, this takes a proprietary connection, so we don't have that that allows you to plug into like a low flow adapter. So I'm just showing you that it's there, but we're not really going to use it. We're primarily going to use this port right here with the green connection. I do want to show you the power port or the power plug. I know the cord is screwed into the side of the ventilator, but I want you to try to pull that plug out. Because when you pull that plug out, you'll see how there's no friction hardly holding that plug in. It comes out pretty easy. And so that being said, our ventilators, I believe, are going to be deployed with these like red bags that like our Zoll monitors where they have the 2 pockets. So that part is going to be kind of enclosed. So when you go and plug the ventilator in and you're not seeing the 2 green lights on or you're not seeing the lightning bolts above the battery, that would probably be the first thing I would check, is to make sure that port is pushed in all the way. And then I would check to make sure the chuck inverter is on if that was the case. They have this vent here that you don't block. Even in our bags, we have like a little perforation that allows the airflow. Not really the end of the world. Okay, so when you look at your circuit, I have a non-reusable one. So mine's navy, but you guys will have a clear one that looks like this, right? And so when you open the new circuit, your clear one actually has a cap on it, on the end of the diaphragm. So when you go and remove the cap, this could happen, right? So that rubber diaphragm is either in the cap or it falls off or something happens. You absolutely need this piece to function, right? And so it actually has to fit on the valve properly to function. It could only go on one way. If there's a little tick mark on it, yes, I know you could force it on, but it's not going to work in your favor if you try. So just make sure it goes on the right way. Make sure it's securely around that lip and there's no like creases, bubbling, or anything like that. The rubber diaphragm is the one that goes into the ventilator. This exhaust port is always pointed down. You're going to seat this in as far as it goes, as deep as it goes, and then you give it a quarter turn, and the wings should lock in the tab. So you guys can go ahead and do that now. So this is a big component of your ventilator. So when you start doing your pre-test, your pre-ops checks, and they're failing, this would be the first part that I would go to, is make sure that rubber diaphragm, everything is intact. The clear ones are intended for one use only. The navy blue ones, which should be on, will eventually make its way to the BC trucks to help support you. These are the reusable ones. I will say that these don't really get contaminated, right? And so like the patient's stuff doesn't necessarily touch this. And so that being said, if you have an opportunity to accumulate these, like as you switch out circuits and stuff like that, it might be in your favor. Like I would accumulate one, put it in the red bag, accumulate one, put it in the vent bag. And if you even have this to protect the diaphragm, I would also do that, just in case, in the event that something happens and you need a second one and the BC is not there with a reusable one, you have this as a backup, right? The good thing about this is, generally speaking, once you install this and if you decide to remove the circuit, you can leave the valve in. So once you install this and it's been perfect and it sits in there, you can just leave it in there. You don't have to expose the diaphragm to the elements and everything else. If you decide to do your like remove the ventilator, or take the circuit off, this could stay in and it would look like the picture from before. All right, so next, this is the other half of the magic, the flow sensor, right? The cool thing about this is it measures the milliliters from this side on. So we can add neb treatments, everything else in between, but when we say 500 mils, it's measuring 500 mils from here onto the patient, so that we know the patient is getting the 500 mils short of the ET tube and everything else. That being said, if you look inside the flow sensor, you see like a little clear plastic membrane, and it's like a chevron cut. So when air is going through on the inhalation, that trap door, the chevron membrane, goes away, right? And so when the patient exhales and air is coming back through the circuit, the chevron goes that way. So when I say that, we have to do a flow sensor check, right? We're checking to make sure that this thing is working and measuring properly. So in order to do that, we have to put air through it. Air only goes one direction through this circuit, right? And so when you have it like this, yes, it'll send the inhalation phase and measure it appropriately. But then when it wants to test the exhalation measurements, you have to turn it around, but it doesn't go on, right? And so that is where this adapter comes into play. And so what this adapter does is allows you to plug it in. It doesn't matter if you do the fat side or the skinny side, but it allows you to flip the flow sensor and go hands-free with it, right? So again, this adapter doesn't touch the patient. But how it comes is it's clipped in to the side of the flow sensor tubing, right? And this could happen or whatever happens, and it's gone. So what we encourage is when you're done using that adapter, thread it through your tubing like you see in that image to help prevent you from losing it. Also, doesn't get contaminated by a patient, doesn't really get touched by a patient, so accumulate these in the same fashion. Put it in your vent bag, put it in your red bag, put it in wherever. Also, at the end of the day, it's just an adapter that allows you to do this hands-free, right? So if you find yourself in a position where you have to do this pre-ops check and you cannot find this to save your life, you simply can just hold this over, make sure it's flush, and air will go through and it'll measure it and it'll still work, right? That's in the most not preferred way, but I'm just giving you a tip to make sure the ventilator works for the patient. So, any questions on what we've covered so far? The ventilator itself, the configuration that we have, we could safely ventilate somebody down to 22 pounds. If they're less than 22 pounds, you should be using a neonate circuit. Our district has elected not to go with the neonate circuit because for neonate transfers, those get picked up by Glennon and Children's. And if the other option is in the field birth, the field delivery births. Well, out of all the field delivery births that we've had, none of them have really been transported intubated, right? They've either been neonate resusc or they just do a BVM and iGel. And that's actually a preferred treatment. I would much more prefer you iGel a neonator or bag a neonate than try to intubate them because there's just so much complications that could occur. But at the end of the day, if you absolutely have to use the ventilator on this kid, your pressures are going to be a little off. 9664 and Greg, myself, will have like a strategy where we do low pressures and you're just looking for chest rise. So at the end of the day, if that's a situation, you should have more help than you need, but reach out and use that strategy. But again, at the end of the day, if that baby needs to go somewhere fast, and you don't have time to wait, just bag the kid and get them to where they need to go. But it's pretty infrequent in our system that we need a neonate circuit, so that's why we don't even carry it. And then that adapter allows you to use the flow sensor on a neonate circuit. That's the other purpose of that adapter. All right, pre-ops check. So everybody go ahead and connect your circuit if you haven't already. And once you've connected your circuit, go ahead and turn the ventilator on. So when you turn your ventilator on, there'll be a QR code on the loading page. That QR code takes you to the Hamilton University. Most of those videos are like the robot narrative videos, like beep, boop, like you press the power button, like, so it's not as friendly to view. So what I would encourage is that you would do, there's a YouTube Hamilton group or like their YouTube page, and pick the videos out that it's a human narration and a human activity, and those are pretty good. So like, for my non-ninth brain users, or my non-super users, your ninth brain videos where it was like the actual human talking, those are like the better videos, because like, the super users, they got like the worst videos in the world. But there's a lot of just normal human videos, demonstrations of the Hamilton that are really, really great. And so I would encourage you to visit that. Whenever the editing gets done with Dr. Amjad's video that he did for critical care, it is another great resource on ninth brain that will be available to you. So once you are loaded, you'll see the screen right here. Yes, everybody? All right. Lower left-hand side, pre-ops check. You tap that. So the leak test, it is purely that. Like, it is testing for leaks in your system. So in order to test for a leak, it's going to try to send air. You're going to put your hand over the circuit, and when it tells you, and it shows you, you'll put your hand over the circuit, it tries to send air. You should not hear any air movement, right? Because if you do, then it's leaking somewhere. Pressure will build up, it'll pop off, and it'll say disconnect circuit from patient. That means just take your hand off. So when you first start it up, it's going to say disconnect circuit. And it gets kind of confusing because if you get a new circuit, this one will be at the end of this. So when it says disconnect circuit, it really means just leave it open to air, right? And so when it says that, and it'll say, hey, cover circuit. It's got a picture of a dude holding his thumb over the circuit. And like for me, I got baby thumbs, so if I do this, like air still leaks. So you can do this and stop air from coming out. So either way, you're looking to stop air from moving in and out, and then just follow the instructions. The flow sensor test, like we said earlier, it's trying to measure the configuration of that plastic valve. And so you'll start off with the flow sensor, and then what I'll even do is I'll put the adapter on, and leave it open to air, and it sends air through. Don't be the guy that does this or this, right? Because when you do that, you create resistance, and it messes up the configuration. So leave it open to air, and it'll say flip flow sensor. And then if I have this adapter on, I'll flip it like this and flip it like this. Watch your tubing and make sure it doesn't do this because it creates resistance. So pull that tubing aside, it does its thing, and then it'll say flip sensor. When you flip it again, make sure you grab this plastic adapter too and flip it back. And you just leave everything like that, and it completes the configuration. It is pretty sensitive as far as like you have to do it fast enough or on time. So you just keep trying it again. I will say hardly ever when you're failing it that it's a circuit problem. More than likely when you're failing it, you're not performing the steps fast enough, or that diaphragm and that valve is messed up. So let's go ahead and start off with a leak test. And when you pass that, you can go ahead and go into the flow sensor test. All right, so everybody's passed the flow sensor and the leak sensor test, right? Or leak test. So your workflow, the leak test and the flow sensor test are performed on every new circuit or the beginning of your shift, whether it's a 48 or 24-hour shift, right? So whenever you're doing the ZOL 30 defib, this is when the opportunity you would do the flow and leak sensor tests. They're dated or timestamped when they complete. Now, I will tell you that nobody's going to come out and audit you and be like, hey, because you do you, right? But I'm just telling you from advice to do it on every beginning of every shift, because not to dog on the shift before you, but a lot can happen between when they test it and then when you put it on a patient, right? Like they might have a crazy shift where the ventilator's thrown around in the back of the cabinet and something happens to the circuit. And then you go and you try to use it on a patient, 4 rotations later, and it's got this crack in it. Well, when it does, it might not be as simple as throwing a new circuit on and doing it. Like, you'll have to do all that stuff. So now you saw how tedious it was to do it, and you were just delaying that patient care on top of the stress of equipment failure and stuff like that. It's making it that much worse. So it would be ideal for you to do it on the beginning of your shift. Again, like, I get it, life happens. And if you forget the day 1, then just do it day 2. Or if you forget 12 hours in, just do it.
Do you just use the circuit that comes with it? Do you open it up?
Yes. So if you, like say you come on the shift and nobody's used the ventilator, the circuit should be how it is, just wrapped up in that pocket. So you would just do your flow sensor test with that circuit and then put it all back. And then, up to you. So they're saying they prefer for you to keep it connected because when it's connected, there's no leaks and everything's fine, right? But if you disconnect that, the ventilator doesn't recognize it. It doesn't say, oh, you disconnected, we have to do the test again. So if for whatever reason, like say you're pulling it out of that bag, you have to clean it or something like that, you could just disconnect it, leave the valve on if you can, and then do.
Just for storage reasons afterwards, I didn't know.
Yes. So without the bag, it would make sense for us to disconnect it. Like when we were trialing it and we didn't have the bag, I would disconnect it and then plug it in whenever I needed it. But the way the bag is coming, it's literally like our Zoll monitor bags where it's like the 2 pockets on the side. So it'll be encased. So you would just test it, coil it up, and just shove it back in. So like how you do your AED pads. So they would just still be connected. The O2 sensor test. I've had mixed stories on this. I've not gotten clear definition directive on it. Because when we were first introduced it, it was tested once a month. And then at some point, I guess through the super user, they said that they're just going to do it during BMIS. Either way, the short story is every time you test that, you burn through the O2 sensor cell. And that cell is expensive. And so you could do the leak test all day and nothing happens, right? You're not wasting anything. But when you do the O2 test, at some point you'll burn through all the cells and they need to replace that cell. And it's expensive. So don't worry about that. And they didn't let us do it in super user training, so I couldn't even tell you how to do it or what happens anyway. I assume it's just as easy as the other ones. There's probably a picture. So don't worry about that. The 2 things that you really need to be sure of is the leak test and the flow sensor test. And we're confident in that, yeah? All right.
If either one of those fail, can you still use it?
No. So if you have a red X on any of those 2, and you wouldn't want to, right? Because if the flow sensor failed, there's no reliable measurements of. The power button is the green one on the upper or left-hand side.
How about is it, like let's say mine fails, I come up to a service center, pick up a new one, get a call, and it hasn't been checked in a month. Is there anything that says like this has to be checked?
Yes. Well, there's no like definitive, but again, it's safe practice, right? So if you took a piece of new equipment, the first thing I would do is to do that. Because the whole reason that you dumped the monitor or the ventilator you just did was because it failed that test, right? So it wouldn't make sense to take a new, and go. So if you received a different one, I would try to perform those tests just to make sure it's not user error, circuit, or, you know what I'm saying? So yeah, if it is the first exposure to the current ventilator you have, it would be in your best interest to do those 2 tests, or the change of every new circuit. So like this circuit was there, we go and use it on a patient, we come back, we put everything together, we put a new circuit on, then you do those 2 tests. Okay, so this screen right here is already see the screen on there because your pre-op's probably timed out, right? So this is your home screen. So this is essentially the new patient screen, right? If your screen looks like this and you don't have the presets on the left, you're in the last patient mode, right? So new patient, and you see all these settings right here. So the settings on the left, PRVC, BiPAP, ASV, think of it as a book cover on a book, right? If you put a book cover on a book, you can write whatever you want on the book cover, but the book is still the book. What I mean by that is PRVC, it says PRVC, but if you tap it, the mode you are actually in, the book you are actually reading is SCMV. So don't think that you tapped PRVC, look up, and you're like, oh, wait, it doesn't say PRVC. I must be in the wrong mode. No, you're in the right mode. It was just the book cover. BiPAP, same thing. You tap BiPAP, it's going to say NIVST, not BiPAP on the upper left-hand side, because the book you're reading is the NIVST book. And so they felt it was an easy transition for you to have those labeled there in that fashion. ASV is ASV. Like the book cover matches the book, right? And so there's that. Work your way from left to right. And what I mean by that is let's right now make our patient 58 inches female. So tap the height, make it orange, turn the dial, turn it down to 58 inches. Okay, and now you say, hey, I wanted to BiPAP this patient, so tap BiPAP. Yours probably won't change because your control is still orange. There you go. Yep. So when you see, you change the preset, it reset the patient as well. Now, what I will say though, that only happens if you change presets. If you change it in the mode section, like so if you were to click in the upper right-hand side modes and pick your different modes there, it won't affect your patient stuff.
So if we're going from BiPAP to innovation, don't click that button, go to modes.
Correct, and you would do that anyway.
Right.
But yes, so I just want you to know that when you're first setting up this patient on first launch, and it's a work habit for you to use the SCAD presets, which is reasonable, just make sure you work from left to right. Pick BiPAP first or pick ASV first, then plug in your patient information, and then we'll do whatever we do. So, modes. If you tap on modes in the upper left-hand side, you'll see this screen. It's partitioned off, right? So the first one's going to be all your volume modes. The second one's going to be all of your pressure modes. ASV is the artificial intelligence invasive mode, and then your non-invasive NIV, NIVST. So, if it on the top two rows, if it doesn't say SIMV, it's safe to assume that it's AC, right? So, and basically everything on that left column is AC. Then you have SIMV. You see the pressure control and the SPONT? That I see you using more for your trached patients, right? So they're trached, you hook the circuit up to them, and it doesn't give them a rate. It just, every time they take a breath, they get a little bit of pressure support. So it's basically CPAP with pressure support is what that SPONT is. So that would be really what I would envision you would use for that type of patient demographic, or that mode in that patient demographic. NIV and NIVST. How I try to remember it is NIVST is NIV minus spontaneous breaths. So if the patient does not have spontaneous breaths, we have to give them a what? A rate, right? Or a breath rate, yes. So that mode has a rate associated with it. So NIV is basically CPAP with pressure support. There's no rate involved. On the Ravel, when we go to BiPAP somebody, right, we'd set our IPAP, we'd set our EPAP, and then they have us turn the rate down to 0. And inevitably, we forget to turn the rate down to 0, and it's like at 11 or whatever, and then you try to change it, and you turn it down to 0, well, it won't let you. Yeah, it stops at 1, because the mode you are actually in, your breath type is pressure, and the mode you're in is assist control. Well, you can't have a control of 0, so it stops it at 1. But if you wanted a rate of 0, you would just change the mode to CPAP and pressure support, and it would just blank out that mode. So that's essentially what it's doing is NIVST is pressure AC, non-invasive, right? So when you go to NIV, it's just pressure CPAP, the pressure support. So that is the takeaway. That being said, oh, I'm getting ahead of myself. All right, when we change modes, we confirm twice. So what I mean by that is, right now, like I'm in SCMV, if I hit NIVST and I hit confirm, that doesn't change my mode. It just brings another set of controls up, and I have to confirm that before the actual mode changes. So we're going to attach our test lung to our circuit right now, but your typical workflow, you do not have to attach a test lung before you hook it up to a patient like we would do in the Ravel. Because we had to do that in the Ravel to get to our settings and make our adjustments while it's ventilating. You can make all of your adjustments in the standby screen, right? So, for instance, what mode is everybody in right now? Hit modes in the upper right-hand side, if you already have, and then hit NIVST. NIVST starts with an N. NIVST. It starts with an N, ends with a T. All right, so everybody selects NIVST, confirm that. If you're already in that mode, it probably won't let you change, that's why. But once you confirm, you see the whole set of controls. make sure you confirm those controls because they'll disappear, they'll time out and disappear. And if they do, you're like, oh, I'm in that mode, but you're not. You're still in the old mode. So confirm it again and switch modes. So if you were already in a mode and you couldn't change to NIVST, just change it to another mode. Change it to ASV. So, but march through and change some modes around. And see how you're able to do all this without having to ventilate the patient. Another cool thing is whatever mode you're in, we can make adjustments to that mode before we start ventilating patients. I know I just said that. But hit controls on the right-hand side and then turn your FiO2 all the way down, or oxygen, all the way down to 21. So we can start living in real time and make our real-time adjustments. All right, so everybody kind of comfortable with changing modes, not necessarily what each mode is, we'll go more into that, but if you're comfortable changing modes, we'll push on. Yes, sir.
So in the past, like for the Rebel, I've had a patient that's COPD, crashing, respiratory failure, and then you know that you're going down the path of you're going to intubate, and while you're prepping, with the Rebel, I've found that you can use a setting to almost be.
Yes, they'll be in the ventilation strategy. So.
I don't want to get ahead. That's where you're
Yep. We'll parking lot. If I don't answer your question, we'll circle back to it. But we'll say ventilating on crashing patient. When you start ventilating, everybody, no matter what mode you're in, you'll see a screen like this, and I'll demonstrate here in a minute. But you'll see the patient gender on that left-hand side. You'll see the mode that you're actually in. Let's go ahead and do that. Let's put it in ASV and start ventilations. Everybody hit ASV and start ventilations. Make sure you have a test lung attached. So you see that alarm is where that's showing up. So the light's blinking and then that alarm space. All right, so you can go ahead and put the vent on standby. So you hit the power button and hit activate standby. All right. So mode selection button is right there, allows you to change modes. Your most commonly adjusted controls are in that section. So on the right-hand side is your user inputs. On the left-hand side is what the patient gives back to you. So your controls are right there, and if you want to see more controls like you guys have been doing already, you hit controls and then it gives you additional settings. But the most common three are essentially going to be the elimination of end tidal, PEEP, and FiO2. And then again, if you want to change more stuff, you'll see it into the controls. Your battery life is going to be down there. Make sure that you have 2 lightning bolts, and if you don't, then more than likely the plug came off or your inverter is off. And this one right here is that silence alarm that we talked about earlier, and it'll count down. Waveforms. I don't know how we've not been using these on a ventilator, and it is a huge impact to our patients. So the top waveform is the peak airway pressure waveform, and that doesn't ever go away. That is always on no matter what you change. The other 2 waveforms you could change by tapping on the screen and selecting different waveforms. But these 2 are very, very valuable. The reason why they're valuable is every negative deflection, right? So it's 0 and it goes negative. That's the patient breathing against the ventilator, creating negative pressure. So that's the exhalation phase. Every positive deflection is the ventilator forcing flow into the patient. So that's inhalation phase. So by this waveform, how many breaths has the ventilator give the patient? 2. Perfect. So it looks like this because it was on a test lung. I heard somebody had like a rate of like 100 on their ventilator. But it's important because this deflection, you want it to come back to baseline, to 0, before it gives the inhalation phase. So if the patient was exhaling, and all of a sudden the ventilator is like, hey, it's time for your breath, boom, and it doesn't get to 0 and it shoots right up, well, that's signs of breath stacking, right? And so now we have a visual representation real time of breath stacking. And if our waveforms are marching on top of each other, or all we see is inhalation forms and no exhalation waveforms, then that's another sign that we're failing the patient in properly giving breaths. So super important. This is your volume waveform. That's just as important too, because every breath of volume. So then that gives us an opportunity to see, hey, my volume breaths are trending down. Like, am I, then we go into our dope, right? Like, are we displaced? Are we obstructed? So on and so forth. So those are your waveforms. Patient returns. P peak. So we know that as PIP, PIP, but now we're measuring in P peak, P peak inspiratory pressure. Exhaled minute volume. So like I said, you see it now. It's not VE, it's min volume. And then the tidal volume is VTE, exhale tidal volume. And then F. Who can tell me what F is?
Frequency.
Okay, what does it mean?
How many times you have to breathe?
Yeah. So when I self-taught, I had to figure it out. I had always said F was respiratory rate. And I was wrong, right? Respiratory rate and F are two different things. And the why they're two different things is because respiratory rate is what I dialed in. Frequency of breathing is what the patient is actually doing. So our SCCAD protocol, our respiratory rate is 15 if we did any of the presets, right? If my F is 15, what can I assume about that patient? Yeah, no spontaneous breaths. You are not that good to dial this ventilator in perfectly in sync with the patient. Like, more than likely, it will probably be 16 if you're that good, right? So if I want 16, I can assume I have spontaneous breaths. Deal. What if
They're breathing and you're breathing too fast for them. Your respiratory rate and they're breathing, so you're breath stacking basically.
potentially, but I'm more so in the simplest form, I'm out of sync, right? Like there's no mesh in between. Like somebody's not happy at some point, right? It could be AFib breathing. It could be fine. Like my 15 breaths march out in between their breaths, so it might not be that big of a deal. But definitely a ventilator patient dyssynchrony, right? Let's talk about even the most extreme. Heart rate of 80.
Would it be compensating? Because I mean, you're trying to keep up with it, and their heart rate's still pretty low.
Are you taking away their cardiac demand? So their heart rate would be slow.
So it's even more than you guys are overthinking it, but every time the heart is beating, there's a breath. That usually doesn't happen, right? That's weird. And so what's weird is it's sensing the interthoracic pressure change of whatever, if it's a bounding pulse or something's happening, and every time the pressure changes, the ventilator's like, oh, you must want a breath, and it gives a breath and pressure support. So what can we do to stop that? Yes, it's too sensitive. It's sensing the changing of the pressures. So in order for us to change our sensitivity, what mode are you guys in right now? ASV. So click on controls. And it's actually called flow trigger, right? So as you turn that trigger up, it should make it less sensitive. And as you turn it down, it should make it more sensitive. So this is an exaggerated. This is like a crazy scenario. But if it wasn't this, and it was this, you're like, still not that crazy, but what would be crazy if this dude was rocked, right? Or like heavy versed, and you look at it like, there's no way he's generating his own 13 breaths on top. So what more than likely is happening is the sensitivity of the truck bouncing, making the pressure changes in his thoracic cavity, making those breaths, right? And we only know that by paying attention to our respiratory rate and contrast of frequency of breathing. And now if the truck is generating breaths, we can now adjust the sensitivity. So now we have the tools and things to make sense. Because I promise you, in the years that we've used the Revell, who's touch sensitivity? Yeah, you never, and you're like, what reason would I have to? Because you didn't know any better. But now you know better, right? So if this doesn't match up and the story doesn't make sense, if this didn't match up and they were conscious, I'm not saying just a sensitivity, like that's happening. But if they're paralyzed and they have spontaneous breaths, it's your sensitivity that's jacked up. So you change that to effect. When we talk about pressures, it helps to understand how the vent works, right? And the vent works off of essentially diffusion. So ventilator, ET tube, trachea, and then lung tissue, right? So what do we say PEEP was? Or intrinsic PEEP. Like, what do you know it is? 3 to 5, right? And so let's say PEEP of 5. So exhalation phase, 5 centimeters of water. Let's say this, for instance, for the sake of easy math, we've turned the IPAP, inspiratory pressure, to 30 centimeters of water. So it wants to equalize. So all this pressure is going to rush in, and it's going to try to rush in and to equalize. When it equalizes, and they're both 32.5 during the inspiratory phase, there's this pause, right? So it's going to rush in, have this high peak pressure, and then it's going to drop down and find the equalization. And so that's your plateau, and then they exhale, right? So a normal ratio, so this is your P peak, and this is your P plat. Your P peak is a measurement of resistance up to lung tissue. So if the tube, humidity, mucus creates more resistance, your peaks will be higher, right? Because it's a higher pressure that's got to be forced through. But lung tissue is assumed by the equalization. So if Shaq was involved in a house fire and you tubed him with a 602 because that's all you could get in, you've increased his normal resistance, right? Because Shaq's normal airway is like probably 10 millimeters, 12 millimeters in diameter, and we've reduced it down to 6. So we have higher resistance now. So when we're trying to give 30 centimeters of water, or 30 centimeters of pressure in, we're creating resistance. We have this high peak. But guess what? Because we've made this resistance and made reduction, we're not getting as much volume, right? So when it equalizes, it's going to equalize down here. Because he probably would have only had 200 mils of volume because the inspiratory phase ended, but it wasn't high enough pressure because your P limit was 30. So now we get a low minute volume alarm. Now we get a low tidal volume alarm, or we get a P limit alarm, P limit reached, which is saying, hey, you told me I can't go higher than this pressure, but I can't give you the volume that you need with that pressure, right? So what do we have to do? Turn up the pressure. We know the volume we want, so that's why the ventilator knows. But it's not getting it because of the resistance. So we have to turn up the pressure, right? I told you earlier that the P limit, the normal, is less than 30. But that's just to start off with. We've introduced something that's not normal to the patient. It's not normal for Shaq to have a 6-inch diameter trachea. So now we have to overcome that. So we can now overcome that because we have a P plat measurement. And if say our peak was 50 and our plateau pressure was 8, we could go up much more in pressure. So it's very reasonable for a burned Shaq to have a P peak of 80 and a P plat of 8, right? Because we have all this resistance but we're not really affecting lung tissue. Does that make sense? So this is just a red flag, but this allows you to be a paramedic, right? And so if you say, hey, man, this is not normal, and you stop at 50, and Shaq's only getting 40, 400 of tidal volume, and you're like, I can't go higher than 50 because that's outside the normal range, you're doing a disservice to the patient because he's not getting the volume he needs. So you look at your plateau pressures to help drive your decision. So when you show up to the ER and they're having P peaks of 90, and they're like, oh, why'd your tube shack with a 602? Like, hey, his freaking airway was completely swelled up. This is the best we can do. Well, it's unsafe. It's unsafe. His P peak's 90, but his P plats are only like 12 because that's the lung tissue is uninjured. Does that make sense? So understanding how that ventilator and diffusion works and how the measurements are obtained kind of give you so like a normal ratio we said was like 30 and then 20, right? Your P plat's less than 20 and a P peak. So this is a normal ratio for that patient. But for Shaq, we've made it 80 and 8. So when I would crank this up to 40, my P plats would go up because my ratio was so tight and narrow. But the patient that we made Shaq, I could crank this up a lot and still not affect his lung tissue. You see what I'm saying now? Does that make sense? Mm-hmm. And so don't be scared. Pay attention. It should be a red flag and it should be a little uncomfortable, but don't let that decide on how you ventilate the patient exclusively. Make sure that you get your plateau pressures.
And on this, where are we seeing our plateau pressure?
I'll show you in a minute, but it'll be monitoring on the lower left-hand side, page 3. And so how the Revell, how we're used to getting our P-plats, the Revell was a valved ventilator. So you'd say, hey, inspiratory hold, and you had a tidal volume. So it would push 500 of air into the patient and shut this valve, and it would just measure this back pressure, and that would get your P-plats. This ventilator is a pressure ventilator, so everything's built on turbines. So when it says, hey, give 500, it's giving 500, but it's still spinning. So there's no valve where it can like shut off and hold. So there's no eye hold. So that's why your P-plats aren't performed the same way that they were with the Revell because of the way the ventilator is designed. So it actually calculates it mathematically by the pressure and the flow. Pretty accurate, so it's pretty reliable. So that being said, sometimes you don't always get a P-plat because the variables occur so much with the patient if they're not breathing in a pattern, if they're like this crazy Kussmaul and you don't have the opportunity to fully measure the inspiratory phase, your P-plats will say dash, dash, dash. And so just know that can happen, which is okay. Then you have to drive exclusively off a P-peak. But if you have a P-plat, let your decisions drive off of that. Any questions on P-plat and
What range are you looking for P-plat? Does it matter?
P-plats is almost all the time less than 20. Yep. Anything higher than you're getting really close to barotrauma. Again, how we attach everything. Everything that you add onto the circuit goes on the vent side, right? And so everything on this side it should just be patient. So whether it's the little corrugated tubing or this should be only patient. Everything else you add is on this side. So if we were to add end tidal, HME filter, neb treatment, flow sensor, patient, working that way. Does anybody have any heartache about this order? I'm like, I don't like this, right? So number one for me, the HME filter is. I'm gonna assume you guys don't know this, they were kind of taught wrong in medical school. So the HME filter is basically a ghetto heat moisturizer, humidifier heater, right? And so what that means is there's a little membrane in it. When the patient exhales, the humidity and temperature of the exhalation from the patient warms this membrane and gets it wet. So when the breath comes back through, it's moisturized by the humidity of the exhalation from the previous exhalation, and then it's roughly 90 degrees from the patient's temperature, right? So it's not a heated circuit, it's just a heat moisturizer. So when you're taught that, they say, hey, this should always be as close to the patient as possible, right? Because then it's going to accumulate the most moisture and the most humidity and the most warmth. So that's how I was taught. The HME filter always goes as close to the patient. So I put this HME filter on, and I started a neb treatment. And I'm like, man, my waveform is like not improving. And I'm like 3 albuterol in, and I'm like, what is happening? Yeah, my stupid, me dumb, my filter was blocking everything, right? So I learned to put the HME filter after or right before the neb treatment. Anybody have any heartache with the end tidal? So what I've been some of the feedback that I get is if you put the end tidal on the far end of the circuit, you're not going to get reliable readings. So then people want to put the end tidal as close to the patient as possible, or they want to do the nasal cannula end tidal. To me, when you do that, it's no different than you doing a blood pressure and it's low, and you shake the patient's arm next time and you cycle the pressure to get a higher reading, right? Because that end tidal is only maybe 200 mils of tidal volume away. So if you're not getting measurements of 200 tidal volume in distance, you're not letting the patient exhale. Your PEEP is too aggressive, and they can't breathe against the ventilator. And so yeah, of course, when you put a nasal cannula in here and you're measuring all the turbulence, it's going to work, but you're not ventilating the patient properly. If you're ventilating them properly, the end tidal, they should have an end tidal reading. I encourage, especially when you go to the intubation, to use the filter in front of the end tidal. We've all tubed that cardiac arrest patient where you go and you drop the tube and all that pink frothy stuff comes up, right? And you put your tubing on and your partner's like, hey, end tidal 0. And you're like, dude, I know I watched you go through the cords. And you're like, I don't care, your end tidal's still 0. And like, oh, it must be the sensor. And then so you mess around with the sensor, you get a new one, and it's like, hey, end tidal's still 0. And then you're like, you're frustrated now, and you're like, F it, and you're like, I'm gonna go retube the patient. And only find out that something traumatic may have happened to the patient and it wasn't even the sensor problem, right? Having the filter on the front end eliminates all that. When the filter's going to absorb all of the pink frothy stuff, it's not going to obstruct the airway. Air will still pass through, but it's not going to mess up your end tidal sensor. So if your end tidal 0 with a filter on it, that's a reliable 0. Like you need to do something else with your airway, and it's not an end tidal sensor issue, right? And so that's where I would encourage you to do that. Neb treatment. We are getting their proprietary neb set. And so what that means is their proprietary neb set, this T-piece, it's going to be blue and it's spring-loaded. So there's going to be like a valve here. And when you go to insert this up, it pushes that valve and lets the neb treatment in. And when you go and remove it, the valve closes, and it's a closed circuit, and it can still, yeah, big deal. Like, who cares, right? The big deal is that in their infinite wisdom of making you spend more money, these connections, this one in particular, is not a standard connection. It's a proprietary connection. So if I have a regular T-piece and I put it on here, and I go to put this on, it doesn't fit, right? So I say that we are getting their proprietary piece, but in the event that you pull up, your portable O2 bag and you don't have the T-piece in there, our T-piece with this corrugated tubing, you put it on here, and the hub of this is a standard size. So what you're going to do is you're going to just ratchet it on, and it'll fit. I've been using it for every training, so this piece is kind of like loosening up. So if I were to use this in real life, I'd probably have to hold it. You could certainly try to tape it, but this at least gets it working for you, and you can start your neb treatment with the equipment that you have, right? Yes, it is not ideal, because if this was on like a mask, like you see this, right? Now, we all have been in the boat where you start a neb treatment, and it's like 2 mils left, and it's like, and you're like doing this, and you're trying to hold it to catch it, right? And because that's a volume problem, there's not enough volume to catch the pressure, right? So in that instance where the thing rests like this, just do 2 treatments. So do 2 a duo neb, or if you're like, oh, that's too much, then do 1 of duo neb and 1 of saline, the pink saline, to add volume. Because when you add more volume and it does this, it's still going to catch. Does that make sense? Now, I told you we're going to run this here, from here to there, and do our neb treatment. And again, every breath, it gives it, and every exhalation phase, it doesn't give it. Some of the advantages of why that is beneficial, where 1, it extends the life of our neb treatment, but 2, how the ventilator functions. So if this is my ventilator, and this is my patient, circuit going to the patient, and then the exhalation circuit coming back. There's the constant flow of air, always. So the flow of air is generally 5 liters per minute. So 5 liters goes up to the patient doesn't do anything with it. Doesn't steal it away, then 5 liters comes back. Ventilator says, hey, I got my 5 that I sent out. You must want nothing, so I'm not going to do anything. 5 liters goes up to the patient. Patient steals 2 liters of flow from drawing that breath in, right? So now 3 liters comes back to the ventilator. Ventilator says, oh, I'm missing 2 liters, so you must want a breath. So it gives a breath. It creates the pressure support or inspiratory phase, right? So when you turn up your flow sensor's trigger, the patient has to steal more breaths to trigger a breath. Does that make sense? They have to, so if right now the flow trigger is 6, the patient has to take steal 6 liters per minute of flow. But if you turn it up to 12, they can do this, but you're not setting the marker high. The patient has to go, and then the ventilator's like, oh, you want a breath. So does that make sense why the sensitivity, as you're turning it up, it actually makes it less sensitive because you have to generate more flow to trigger a breath. Because I had to wrap my head around that too, like it didn't make sense to me. Yeah, but as you turn the number, it's saying that that patient has to steal more flow from the circuit in order to generate that breath. Now, that being said, with 5 liters, I start a neb treatment here, T-piece, and I run it to the truck. What do we run our neb treatments at? Lies. I know you guys just crank it up until it goes, right? But I'll play the game. So we say 8. So 8 plus 5 is 13. Go up to here. We steal 2. 13 minus 2, 11. Come back down here, ventilator says, I don't care that you gave me more flow, you just didn't take any more than I was trying to give you. So ventilator does nothing. There's no pressure support, no inspiratory phase. So it just keeps going. Even though the patient's still breathing, they're not stealing anything. So then you're going to get an apnea alarm. Does this happen every time? No, because we've all done this to the truck and the valves worked fine. But it can happen, right? And so that's one of the possible disadvantages, and that's what else is doing. One advantage of doing it this way and hooking it to the truck is a refinement. This is like being like the sexy paramedic, right? So you can certainly run this 99% of your patients and be fine. But one reason to refine it and run it to the truck. So when we teach a new medic student the MAD device, the atomizing Narcan, what's a very specific instruction that we tell them? How do they administer it? Fast, right? Because what happens if they're like yeah, it just comes out, right? And so that's the difference between nebbing at 8 and nebbing at 15. So if you neb at 8, the molecules are a little bit bigger. If you neb at 15, it atomizes. It's a higher pressure, it really atomizes it. So how does that help the patient? Well, if you hear monophonic, like just one wheezing sound, and it's upper airway, we want to neb it low. So the molecules are big, it gets attracted and stuck at the upper airways. But if we have lower polyphonic, it's like, and it's like all lower airway constructions in the bronchioles, if you neb it at 15, the molecules are a lot smaller, they get atomized, and they pass through the upper airways and get absorbed in the lower airways where they need it. So that's just a refinement and being the next level paramedic and thinking deeper in. But if you don't have to do that, I'm just offering it to you. You certainly could just do all of your neb treatments through the Hamilton on itself.